everyone. You ready for another student Q&A webinar? This is number 5 since we've tried the new format. It's working out great. It's been a while since we had one because, like Boyd was just saying before you guys all came on, we've been doing so many other things. We've got so many CEUs for our club members now. It's really exciting. But this is one of my favorite things to do, is to have a student Q&A webinar. That means that we'll discuss and go back and forth questions and things. And Boyd, can they talk? Are they able to ask questions or not? Strictly through typing?
Well, we could definitely turn them on if we had to.
Okay.
It'd probably
Well,
be better if they ask questions in the chat, yeah.
Okay. Yeah. All right. Well, I just opened it up. I didn't think I could, but it opened up just mighty fine. So feel free to ask questions as we go. We are going to dissect a couple case studies tonight. The first case study that we're going to do is an op report that was sent in by one of our club members. So this is a real op report that has been redacted, and it was a little unique, you know, about how to get the proper code. That's why she sent it in. And so what a great way for us to take a redacted op report and pull it apart. Anything that we don't understand, we're going to go look up. Then the second one is, the first one's going to be coding of a dehiscence case. If you don't know what that is, let me know and I'll explain it in more depth. And then our second one, which I'm going to go ahead and show you that slide real quick so you can get the topics. Twin pregnancy with complications. This was actually sent in by the same club member, these two. I think that was last week or the week before. Excellent cases to go through. So the first one, let's go ahead and bring that up. And I went ahead and downloaded these so that they would be easy to see. And you know what? I'm going to go ahead and make this a little bit bigger. Let's see, it's at 100%. Let's zoom it up to 200 might be too big, but let's see. That going to mess you up, Boyd, if it's that big? Maybe not. Okay.
Yeah, that's too big. Take it down to about 150.
Okay. 150. We can do that. Or even 125. Or I could just put my readers on too, but I think that helps it above it. Okay. So there's 125. So what we're going to do is we're going to talk about this, and I want to break out some of the things that jump out at us. I don't know why that. Oh, there we go. When you're looking at an op report, now normally this is redacted, so everything that indicates, you know, who this belongs to, from the patient's name to any background stuff that might be pertinent, even the place where it happened is taken off. So all of the stuff that you would normally see at the top there, it's gone, right? It's not going to be in there. But the stuff that's pertinent for us to know is still there. So we've got a 62-year-old male. Now, he suffered an injury to the left scalp after being hit in the head by a tree branch. Now, this obviously is a pretty significant tree branch because it did some damage. So we since this is an op report, we really don't have to do the location codes, those Z codes that say, you know, what he was doing and things like that, because his initial visit would have that. Right, so that's important to know. Although being hit in the head by a tree branch is codable, okay. The patient had. You'll see here they've already been to the ER and gotten stitched up. Right? Does anybody know what a dehiscence is? Dehiscence. Do you know what that? Not know what that is? If you do not know what that is, let me know and I'll explain it a little more. Like I said a little bit ago, but this patient comes in to the ER and they stitch up his head. Right? They clean it up, stitch it up. So that's not what we're coding. This is not an initial visit. Right. Even if they had come in through the ER and they had done this in the ER, again, it would be coded differently. But right here, we noticed here, this statement right here, the patient states that the wound was closed in the emergency room department by the ER doc, okay? So it's been done. Here, this is where the problem starts, that the wound has opened up and has a purulent drainage. Is there anybody that does not know what purulent means? Anybody? It is a you're weeping something that's probably infected. Yes, Chelsea is right. She said, "Is it pus?" Yes. You know, so it's not a clear serous fluid that sometimes comes with wounds. You know, when you skin your knee and you get that clear liquid that it's almost like it bubbles up to the top, right? That's serous. Okay, that's the body trying to protect itself. And but purulent, it's doing the same thing. It's trying to protect itself, so it is releasing that serous fluid. However, there's white blood cells all over the place and infection because it's something's gone wrong, right? So there's that, and that's literally why it's white. It's white blood cells, and then the infection will cause color as well. Okay, so they don't talk about the color, but sometimes they will when they say purulent. But if something has purulent drainage, that means that it is dripping, there's liquid coming out of it, and purulent is not a positive thing, right? So if it was weeping or seeping or doing something, and it was just clear fluid or blood, that would be described differently. So that tells us two things. We have a wound that had previously been stitched up. Doesn't matter that they don't tell us how long ago that's been. It doesn't really matter because the disease process and treatment should tell us that when they stitch something up, it usually is 7 to 14 days that you're stitched up, you know, depending on what it is. So we know it's been within a week to 2 weeks that this has been done, because he still had stitches. But a dehiscence means that the stitches opened up, the wound opened back up. That's what a dehiscence is. And sometimes that's okay, right? Because the reason that we close wounds is so that they can heal better, not leave scar tissue. And because wounds, we want them to heal from the inside out. But as long as it's a good slice, a good clean thing that you can put together like this, then they can stitch it up. But you can't put something together like this and sew up the top. That's negative, because that inside, anything under the top, warm, moist, dark space will result in an infection. So all sealed up, and it opened up, right? So usually, depending on how big of an opening, they'll pack it and let it heal from the inside out, and then you'll have a massive scar, right? Other times, that's not going to be a good thing to do, so they go ahead and they close it back up. Now, we this still takes about the same amount of time to heal when something's opened back up, but actually it probably feels like it heals faster, because when it's closed, it has less tissue to fill in, right? And it gets almost ulcerated or something if you have this happen. So it takes longer to fill up a hole than it does to just take the top. Okay. Plus, look where we did this, the scalp. There is just not a lot of meat between the top layer of your skin and your skull. I mean, you're literally talking about this much, probably not even an inch, right? And the head is very, very vascular to give lots of blood vessels go for the brain. So again, that can be problematic. But if you have a significant wound on the head and it opens up, one thing that you have to worry about is scar tissue doesn't grow hair. Okay, so let's say you got a hole in your head, the top of your head. They pull it back together. It opens back. Okay, so the hair will grow. You'll have a scar, but it won't be very big. But if that opens back up, in between there will be no hair. Okay, that can be problematic or not, you know. Also, you are very close to your brain. You don't want to have an open wound that close to your brain that can have infection. You're looking, it's bad enough having an infection in your body. You just don't want an infection that close to your brain. Not a positive thing. So again, those are some problems that we're looking at. So what does the patient do? They go back to the ER. So we presented to the ER for a second time. He was found to have this dehiscence of the wound, meaning the wound just came open. He blew some stitches. Okay, and what I would advise you to do, and normally I would jump out on the web and show you, but my internet is probably not up to par right now. So I would show you some wound dehiscence. So I would just ask that you go do that. Go out and Google image dehiscence, wound dehiscence, and don't do that if you have a problem with looking at open wounds, because they'll be very, very graphic. But you need, it would be a good idea for you at least to go and see and understand what that looks like, because once you see the image, not one, you can't get it out of your head, but it will help you understand the disease process and the treatment that is involved with a dehiscence and why you code it the way you do. So, so there was the drainage and an odor that also indicates we've got an infection, because blood has the normal, it smells like iron, and regular fluids that come out of a wound, again, not so bad. It really doesn't have much of an odor, but odor indicates infection. Okay, so what do? They do what you would think. They explore the wound in the ER. So they go and they look at it. And he says, because there's the presence of this fluid, and this is where I was telling you, the risk of meningitis. Why? Because you've got an open, infected wound on the head next to the brain. What is meningitis? That is an infection in the brain. That is an inflammation of the meninges, and that goes right up the stem of the brain, and you get meningitis, especially a 62-year-old man. He's not recovering. Meningitis is something that is very difficult to, unless it's caught very quickly, it's not a good outcome usually ever. So they decided to go ahead and wash out the wound and close it, but they're not just going to do that in the ER. This is something that they're taking care to do. So they actually are going to put him under. That changes everything. That's why we've got an op report versus just a regular ER report. Okay. And I'm sure his age has a lot to do with it. We don't know what his comorbidities are. Unless it's documented, we don't know. And it doesn't, I'm sure it gave you this information on the redacted stuff, but if he has any vascular condition, then we've got poor circulation. And if he has, heaven forbid he's a diabetic, that would be really bad. But at 62, that's really not old, but things are slowing down in the body, right? They're not at peak performance anymore. So if you had a 30-year-old versus a 60-year-old that had this wound, they may not treat it the same. Okay. So again, they got consent to go in. So really, this is we don't care about this, right? This is kind of fodder to the consent. It says he understands the wishes and wishes to proceed. So that's all of this, the indication for the procedure, the reason they're going to do the procedure is all stated here. And that's our part of the medical decision making, right? Well, you don't have to have that for an op report, but then you understand the medical decision making that went behind doing this versus cleaning him up and stitching him back up. And usually they don't restitch dehiscences unless there is a reason, a significant reason to do that. A lot of times they'll pack it. And when you go and look at the codes for a dehiscence, the treatment, the CPT code, there's more than one. One where there's a dehiscence and they pack it, one that they leave it open. And then I think there's one for stitching it up too. Okay, so it was verified by the patient in the operating room that this is what they were going to do. They got to put this verbiage in there now. So because if it's not stated, that means, you know, and you'll notice that sometimes the op reports kind of seem redundant, like they're repeating things. You know, the patient was prepped and draped sterilely. Well, yeah, of course, but they have to state that, or if the guy gets an infection again or a problem, they'll say, well, you didn't drape him. I say, well, we do that. That's standard. No, you didn't write it. You didn't do it. You know, and again, you have to be very careful. That's why you're going to see all this. And notice that they state the patient was already on antibiotics. So the patient's on antibiotics and it still is has an infection. Okay, so here's where you get into some redundant verbiage. The wound was sharply debrided via sharp excisional technique using a scalpel. That's, you know, speaks for itself, right? But this is important. The wound debrided was approximately 8 centimeters by 2 centimeters. So gosh, I don't even know if I had a, oh, looky there, what I have in my drawer. So let's get an idea of what 8 centimeters is compared to inches. And again, here we're looking at 8 centimeters, and that's inches, centimeters right here. This is 8 centimeters. From here to here is 8 centimeters. Now, you think about that on the top of your head, and 8 centimeters by 2 centimeters would be, here's 2. So 2 centimeters is almost an inch. So it's open almost an inch, and it's that far, you know, 8 centimeters wide. That's significant. I mean, that's like your finger, right? That's about open about this much. So it's an open wound that's weeping pus, ultimately. Could something have been caught in there? If you were hit in the head by a tree branch, you know, there could have been a piece of wood, or no telling, you know, hair from the squirrel that jumped from one tree to another, you know, it could be anything. So the tissue debrided consistent of a full thickness skin and subcutaneous tissue. Now, for this, we probably don't need to know that. However, you need to know sometimes, because they want to know when you're doing debridement and getting rid of tissue, cutting tissue to make a nice clean area where you can close that back up, then size matters. And it meaning thickness too. So size 8 by 2 is important for us to know, as well as they went down to full thickness. They didn't go down to the scalp, right? And like I said, you only got a little bit of space there until you get to the scalp. The wound was debrided down to healthier appearing tissue. So when they say debrided, if the wound is infected and it's probably dying, they literally will cut away anything that's jagged and not looking good. Or maybe it started to scab a little bit. They'll cut all of that off until they've got good, fresh bleeding, because what is carried in the blood is what's going to pull the tissue together and make, you know, God's little Band-Aid there, right? A scab. And so they're taking off the old scabbing, and they want the blood to come in, and the platelets and everything to come in and do their work. So they also scrubbed the area, made sure that there was no debris in there, and they looked for a healthy and bleeding tissue. If it bled too much, they go and they cauterize it. So they've got this little zapper that kind of looks, well, let's pull this little pin out here. It looks like this, and they wrap it with sterile stuff, and it's got a little wire, and it's, you know, and it literally a little needle type thing, and they zap it and cauterize the little vessel, and it'll stop bleeding. The wound had no evidence of foreign body, so that's good. And if there was, they got it out, or debris. So that's not what caused the infection, or they got the ER the first time, got it all out. Then the wound was loosely approximated with 3O nylon. Now, nylon is man-made and it doesn't dissolve, so he is going to have those removed. And they didn't do under stitches, right, that dissolve. Whenever you see that there's two different types, like 3O nylon and whatever the other one is, then what that means is that they'll pull it together underneath, so it's like this. They'll pull it together like that and understitch it, and then they'll stitch the top. And that's very important to do that, again, because you want no pockets in there. That'll cause infection. And if they choose to pack it, then they don't stitch it. But notice they do it loosely. That's pertinent, because they want air to get in there, and they want it to stay clean, and they don't want to make it so tight that it pulls the stitches again. Think about this. Not only do you not have a lot of skin and meat on your head, on your skull, but it's spread on there pretty tight. There's not a lot of loose skin on your skull, right, to give. And so that's why you would do it. They're doing it loosely so it doesn't pop and pull again as it's healing. So the length of the incision was approximately 8 centimeters. That's important when we're getting the code for that. And then it goes on, it says, now that they've stitched it loosely, they clean it up. It's a wound, and they dry it and put the sterile dressing on it, and then they send him to the recovery room. So now let's talk a little bit about the codes. I want you to have your manuals out. I'm going to go ahead and just pull this over to the side so it's not in our way. And we're going to go over here to the tools and find a code, and we're going to build a code, right? I don't know if you guys have used this tool yet or not. It's very helpful, especially when you're doing codes like PCS, where you don't quite know where to start. Let's see, we've got a question. What if an adhesive like Dermabond was used to close the wound? I thought this wound would be closed with glue because there is an infection. No, you're right. The glue works very well, but think about where it's at, and the reason they probably didn't use the glue, because they use that quite a bit now, but because it's already adhesed once and it's pulled tight, so there's not a lot of elasticity in the skin there. They did it loosely this time. So they did it like this, but they left space in between. So I guess it would be kind of like that. There's the stitches are wide apart and not gapping, so they're going to let it kind of go from the inside out instead of having it like this. It's going to heal, but that's why. I think if it had adhesed someplace else on the body, and it was that size, they would have done that. Plus, we have to remember we got hair there, and again, it normally wears off the glue, but that's a good point to make. All right, so what are we actually doing? Let's get the CPT code. We're not going to worry about it. I mean, I love ICD, and that's real easy to do for us. But let's look at, oh, hey, you can tell I actually looked at this recently. Here is the first code that was thought of. So a repair intermediate, 7.6 to 12.5 centimeters, 12034. So let's see if I can open this up on another thing, and it'll let me do that because it doesn't like to open pages on my internet. Then another code that was suggested was 12020, treatment superficial wound adhesant simple closure. Okay, and secondary closure surgical wound adhesants. Okay, so I don't think that's going to open. I'm not going to try to open that. I'll X out of it. So what do? It here's our choices to go in. And we're not going to worry about the anesthesia. We look at all of these, and it is a surgery code. So we're going to go there, and it's going to give us the options, what to look for. So is it general surgery procedures or procedures? It's surgery procedure on the integumentary system. And we can look at our other, options here, and nothing else really fits. But again, remember, we're doing this, we're building a code. It's kind of like the index, but not. Okay, so we know that we're going to be a 1, starting with a 1, but our others next will be a 0 through 9. So let's pick one. On skin, subcutaneous, and accessory structures, nails, pilonidal cyst, removal procedure on the integumentary system. So introduction or removal procedure, we're not on the integumentary, we're not doing that, right? Surgical repair or closure, yeah, we're doing a closure. Destruction, no. Surgical procedure of the breast, no. So we are doing a closure. Okay, so we're doing a closure, we think, but let's see. Repair simple procedure on the integumentary or intermediate. Now look at our choices here. None of these others really, other repair of the integumentary system, I can show you what those choices are, but I can tell you that's not going to be in there because that's dermabrasion, blepharoplasties. These are like things that you would do for plastic surgery and stuff. Making sure nobody's asking any questions. Oh, I hope I didn't mess myself up by going one page back. No, we actually did a repair. I think I have to start over. We'll see. May have. So we'll go back to build a code. And again, while we're doing this, if you have any questions, you let me know. But the thing that should jump out at you while we're doing this, because I showed you those codes before, is we're doing a repair, but what makes this different? All right, so we did, still thinking, see up here. I'm on a hot, one of these hotspots things. So my internet's kind of slow. Okay, so we did surgery, and we knew we were doing on the integumentary system, and surgical procedures of the skin and subcutaneous. Well, surgical repair or closure. We're going to look at that, but that's not going to give us what we want really. Simple. We wouldn't classify this as simple. Simple is just a whip, 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 right? This is more. They had to debride and everything. So this would be at least intermediate. Okay. So 1, 2, 0, then we've got 3 through 5. And our choices are repair of intermediate, and then it's going to give us areas, and this is of the scalp. So we would do that. And then it goes by size, and it was 8 centimeters. So we would go there. So again, that 1, 2, 0, 3, 4 is the code. However, that really isn't the proper code, because even though it looks right, and you go look at it in the, if you go look at what it states, and I don't think I can get it to open, but I'm going to try one more time. Let's go back. Let's build another code, and I'm going to show you something else that should jump out at you. So we're going to go to surgery again, procedures on the integumentary system. Then instead of going to surgical repair, all right, let's go up here, surgical procedures on the skin. And let's look here. Introduction, no. Removal, no. Incision and drainage, we're not doing an IND. Debridement procedure on the skin, yeah, they debrided. Paring and cutting, biopsy, removal of skin tags, shaving, excision. Now let's go look at debridement. Let's see what it says. So do any of these apply? Removal a foreign body? No, because there was no foreign body. They didn't debride the subcutaneous tissue per se, because the code that we want is actually going to be a 1.3 code. So let's go look at 12034 now that it came up. Repair intermediate wound of scalp, axilla, which is under the arms, trunk, and extremities, including hands and feet. There is the BAT technique that we use that makes these different. And then it says, do not separately report wound repair CPT codes to describe a closure of surgical incision for procedures with global. Okay, that's good to know. But again, that's not the code we wanted. So let's bring up this code, 13160. So let's try to build this again. Surgery. And then integumentary. I don't think. And then surgical, no, that's surgical repair or closure. Let me do that one. 2. Integumentary complex. Why would this be complex? Think about that. Complex repair of the trunk, the scalp. We're going to go on the scalp. Complex scalp size, and then here we got repair complex scalp, arm, legs, each additional. So we need to go there. And let's go look at this code, 13121. You think, well, why is it a complex? Because they did it in the OR. It's not, the other one would have been, just done in the ER. But this one isn't. It's complex. It was so complex that they actually had to put him under. So repair complex scalp. Now, we can do the BAT technique here. It's not open yet. And you notice this only goes up to 7.5 centimeters. So while that's doing that, let's see if we can get this image going. And sometimes these images give you even more information. Complex suturing of torn, crushed, or deeply lacerated tissue. Okay. Now, we don't know if they did layered suturing in the past, but they went and they put him under and debrided all of this. Usually the being layered, meaning all these other sutures, makes a difference, and that's what you would go by. I'm more inclined to use this, and then we also need to use the add-on code, each additional 5 centimeters. So it would be 13121, 13122. That's what I would use. Chelsea says, I thought complex because more layers in the scalp. That's so interesting that the complex because it's done in the OR. Now, again, you're right. There is more layers in the scalp. They didn't go to the bone, but another reason this is complex is because it was already repaired and then it was a disheasance, right? It opened up. And there's an infection, an active infection going on and stuff. So those things also make it complex. And the fact that they put him under, you don't put people under for intermediate or simple repairs. Yeah. So yes, what you're saying would definitely be accurate as well. Layers as well. Yep. Okay, so that's one of the reasons why this particular case really jumped out at me. because of that, because when you're looking at that, we automatically jump to this, surgical closure impair, but trying to determine if something is simple, intermediate, or complex. And if you need more information on that, it'll be in your CPT manual before these codes, all right? Read those pages to determine. But whenever you've got more than one type of suture, that is an intermediate or complex automatically, because they're understitching. Remember, you don't want this, so they do it like this and then like that. That would be complex or intermediate. But whenever they have to debride, search for something, and then this is a more applicable code. Very good. All right, so that was good. Any more questions on there? If not, okay, I'm going to go ahead and bring up the next case, which is going to be the twin pregnancy with complications. Now,
hold on, back up. I think you had two. Did you see them from Chelsea?
I did. We already answered those.
Okay, good.
Thanks. So with this is a visit, there's a couple things we're going to break down. Now, this is mostly diagnosis coding, so we're going to look at it a little bit differently. We're not going to, I'm going to get rid of this one and bring this little guy up. And let's make this big. Not going to try to make that any bigger and mess this up. So this is a fascinating case, and I can't wait to use it as a test question. So it's very good that you're here. Several things that you need to know about this that make OB a little more interesting. So I really appreciate the person. She didn't give me permission to shout her name out, so I won't do that. But this was a cool one, and I can see why she would want a little bit of help with it, and just verify that she was on the right track. So you have a 20-year-old patient. Who knows what this stands for? G and P. I'll give you a clue. G is gravis, or gravided, or Gravidad. This right here. OB history. Right here. G1P0 really is what that stands for. Now, notice they've got it in there twice. All right. So who knows? Let's see, Chelsea, again, great job, Chelsea, for chiming in. One means how many times the person has been pregnant. Correct. So the G is how many times you've been pregnant, and the P stands for how many times you've delivered. Okay. So her history in the past, she has been pregnant once and delivered one. Here, now, as of today, she's pregnant twice. She's pregnant again, and she still has delivered only one because she's pregnant. Okay, so that's what that means, and you need to know that if you're going to do OB charts. That's very, very important. So just a quick overview. This particular patient came in because she came in because she had some complications. This one is, she's 14 weeks and 2 days. That's what they are saying that she is for her prenatal visit. So does that mean she's in the first, second, or third trimester? Anybody know? You can say real quick. Second trimester, that's right, because it starts after 13 weeks. So she's right into the second trimester. All right. Now, what's the problem? The problem is that she was diagnosed with having twins, and she has a DVT. A DVT is a deep vein thrombosis. That's problematic, right? She could throw a clot and it could kill her. She could go into a pulmonary embolism. It can go into a cerebral embolism and kill her. And so this is also interesting because who knows what mono-di twins means? Anybody? Let's see if I can. I think I got rid of my. No, I didn't. Okay, I'm going to let that open up. while that's opening up, let's see if we can do, Chelsea says, is it identical single sac? No. I thought it was too, because it's been a long time since I've had to you break up twins as either fraternal or identical. Fraternal means there's two separate they don't, that means you can have a boy and a girl. Okay, two eggs were developing and were fertilized, and you have two separate babies in two separate sacs. Okay, that's the most common. Identical twins is oh, wait a minute. It's a little bit different. They are identical twins. Mono is, and but they don't share the same sac. I think there's a separator. I think that's what it is. There's two sacs. That's why it's a problem. It's very rare. Okay, so mono, let's see, di twins. Let's see if we can get this. And it is rare and it can be complicated. Let's see, I have two amniotic sacs called monodi or mondi, but sometimes in the same case, monodi twins or momo, they also share the same amniotic sac. Let's see if we can get this. We don't want Wikipedia. That is, and this one says, are monodi twins identical? I believe they may share the same amniotic sac in case they are known as monoanimonic or are not I'm not going to try to say it. Let's see, they may share the same placenta known as monochrononic. Let's see, they are, all of these twins are in the same placenta. Later, the pregnancy of twinning occurs. Okay, let's do a Google image. That usually helps us understand a little bit better. This was pretty fascinating. And the problem is that when you see this, the twins are, there's usually a problem. Let's see if this little graphic will show us real quick. Well, there's one. Sorry that my computer's so slow, guys. Now, later in this case, they're going to let's stop that one. Let's do this one. Notice here, if you can see this without it being too small. Oh, there's the other one. So here you have two identical twins in the same sac. Then you have two twins, two separate sacs. Okay, one placenta, two placentas, and two separate placentas. This is a fused placenta, and this is two placentas. So it has to do with the placenta, honestly, when you break it down. Now let's see if the other one loaded. Doesn't look like it did. I wanted this one to open up because this looks like a really good one, a little easier to see. But of course, images are going to take a time. While that's coming up, though, let's go back. This I don't know if it's going to do it or not. I don't want to waste time on that. Let's try to build in the background. We'll come back and look at it. So back here, we know we have we have a complication, two complications. One, she's got a DVT. That's a major complication. Two, she's got monodi twins. So we'll go in and we'll look, and it'll explain what her situation is. Whether it's, two placentas or one placenta. Then it states that she's just coming into a visit because she's been transferred because she's high risk, and that she was on Lovenox, which is a blood thinner that you give yourself a shot in the abdomen, but she ran out. Okay, so she ran out of Lovenox a few days ago, and she's no longer has any leg pain or swelling. So she's gone a couple days without her Lovenox to thin her blood out, and but she still has a DVT. Right. Now let's go down here. Let's look at her history. Her history: DVT, high cholesterol, hypertension, no past surgical history. But right there, three things. The DVT, high cholesterol, that's probably why she has the DVT, and the hypertension, right? Three things that you're going to code for. She's a former smoker, also really bad on the circulation, but that's former, so that's good. Let's see, doesn't have any history of the family. They don't know any family history. So we're going to jump down through all this other stuff because this is all just part of the op report. Her blood pressures, now again, we are not clinicians, so we don't look at the blood pressures and stuff, but we want to kind of know what's going on. Her blood pressure is doing great. That's excellent. And her BMI is not too bad. She's 191 and she's 5'3", so she's that's okay. Let's see. So let's go back on. Here's the looking at the rest of the information. They did a transabdominal ultrasound, twin IUP with CLRs, okay, meaning they measured the femur and the skull, and the twins were 14 weeks and 1 day, and the other twin was 13 weeks and 6 days. So why is that? Why, how did you get twins that have two separate dates? Well, usually with twins, you will have one twin that's very, very healthy, and then you'll have another twin that is kind of the runt, and because the other twin is getting more nutrients than the second twin, and they'll pretty much always one. It's not that they're feeding off the other one, but kind of way they are. And so that's why you have a discrepancy, which really isn't that much. It's more like 3-day the discrepancy, but you'll see that more in the ultrasound. Identical twins. Oh, Chelsea said identical, I thought, were 2 eggs released. No, identical twins is 1 egg release that splits because they're identical. Right, so they look the same. Whereas if you have 2 separate eggs released, they would be just regular brothers and sisters, happen to be born on the same day. It could be a brother and a sister, but identical twins will always look the same because they're literally 1 egg that splits in half and becomes 2 human beings instead of 1. Yeah. Okay. So the AP, patient's 20 years old. She's pregnant twice, delivered once. Pregnancy, they're saying, is 14 weeks and 1 day, complicated by the DVT. Monodi twin gestation, past medical history significant for hypertension and high cholesterol. That's all problematic. So active problem list, here we've got DVT, high cholesterol, monochorionic dynamic twin pregnancies, can't say that, high risk pregnancy supervision, 2nd trimester, that's just kind of what they're doing, and the history of hypertension, which doesn't mean they're using this history of and history of. We think of history of as you no longer have that, right, as coders. That's what our guidelines tell us. But it's obvious with this documentation that the person, they're stating a history of, in context of that the patient has in the past had high cholesterol and hypertension and still presently has it. Okay, you can prove that. So that is what we would code, and there is a code for this particular type of twin. But let's go ahead and look at the second case that was sent in, which is the ultrasound for this patient. So they come in because the doctor wants they want an ultrasound, and this has been a little bit later. They've got two pregnancy for the second time, excuse me, with one delivery. Okay, and then let's see. The patient's LMP is uncertain. First prenatal visit at the clinic was demonstrating that she had twins, and they did a quick thing to see how far along she was, but they need more information, and this is what they find. There are two fetuses, okay, and the placenta location is posterior, which is very common. Twin A and twin B, and this is the way they will remain, twin A and twin B, until after the baby is born, because these are identical twins too. So they're both going to be boy or girl. Now, sometimes when you have fraternal, when the two eggs, come down and you have a boy and a girl, they may say baby, twin boy, twin girl, but usually it's A and B. And if there's a third triplet, it would be A, B, and C. So fetal presentation for twin A is transverse head on maternal left. So on the mother's left side, the head is transverse. This is why you need to know the positions and everything. Amniotic fluid, all good, because if there's not enough amniotic fluid or too much amniotic fluid, that could be problematic. They were able to do the heart rate, 170. Some tell you that fast heart rate is a girl, slow heart rate's a boy, and all this other stuff, but it doesn't always hold true. People that do this all the time for a living will sometimes be able to kind of tell you. But okay, so twin A's measurement. Twin A is the one that seems to be the bigger one. And look what they do. So the biparietal they're measuring, actually it's the head circumference that they go by a lot, and the femur. That's the two that they go by. So the head circumference is 13.5 and 13 weeks 5 days, and the femur length is usually what they go by, is 13 and 1 day. There's other things that they track and then they average that out. Let's see, so that averaged out to 13 weeks and 5 days, and you get the baby's weight, and they go through and they visualize the baby's heart rate, that its stomach is looking right, they've got a bladder. All of these things are common things to check on an ultrasound. Most often they try to do these ultrasounds at 20 weeks, but again, this was a problem. Twins are always sooner, and she'll have more ultrasounds. Okay, so again, everything looks pretty much okay. Now, twin B. So breech, which means the other baby is transverse. So transverse is, I kind of think of transverses. I was thinking transverses this way, but twin B is breech. So heads up here, feet down here. That's could change, but usually doesn't change with twins. But a lot of times babies will be breech and then they'll flip before they deliver. Okay, so let's look. Heart rate 155. And then we're getting into the head, 14 and 2, and then the femur is 13 and 4. The humerus is the long bone in the arm. They like to go by the long bone, so it's usually the head circumference and the femur. Average is 14 weeks and 1 day, and everything looks okay on the baby status. Look, number of cord vessels, 3. I think that was still 3. Yeah, that's what you want to see. That's the cord, the umbilicus, and everything looks good. So impression from the ultrasound. So we have the twins, and they're going to estimate that the twins are 14 weeks and 1 day, but it's not consistent with what had been indicating. So it's because she's a little, and this is LMP is last menstrual period. And, women usually just don't know. They don't pay attention to that necessarily. And they are basing everything on twin B. The patient has seen the doctor. Okay, we don't need to know that. But the ordered another ultrasound in 2 weeks. They're going to follow this very carefully. Let's see, twin A has a marginal cord insertion, and but it's okay. So we want to make sure this doesn't become a problem. Maternal history, chronic hypertension, and DVT. Pregnancies are concerning for this antibody syndrome. Go Google that. I don't know much about this antibody syndrome. This is antiphospholipid, and it has to do with hypertension and some other things. So you can look that up, get more information. We briefly discussed the risks, okay? Preeclampsia, right? And that's where the placenta comes down, and it can either tear away or try to deliver first and cause bleeding. It can cause problems. Let's see, and that she's going to be back on. She started back on her Lovenox. She needs to do that because of the DVT, because she's a candidate for clotting, and she's going to go through more ultrasounds at this point. All right, and then they did the DNA for the twin screen. They'll be able to tell her even more about the twins with that. So again, approximately 20 minutes were spent with the patient, 15 were spent direct face-to-face time doing the ultrasound. So coding this, you are going to code that she is pregnant with twins. You're also going to code the type of twin, and because it's a complication, then you're going to code for the DVT, and you're going to code for the high cholesterol, as well as coding for the hypertension, and then you're going to do gestational weeks for both of these. On each of these, the consultation, ultrasound, and the regular visit. Any questions? Let's go see then if, there we go. A somewhat technical explanation about these twins. We looked at identical twins. But where is that really good picture? This, you can go look more. Well, this doesn't look as good as I thought it would be. This made eating for 3. I don't know that this is necessarily such a good place to look at. I thought this would be better. Oh, okay. That's going to be it. Let's go. Well, let's build a code real quick for these twins. Let's go to ICD-10. Now, what do we have? We're going to go to obstetrics, pregnancy, childbirth, and then this is not complication of labor and delivery. She's not delivered yet. So, possible delivery problem. Maternal care related to the fetus and amniotic cavity. So look what we've got so far. We got, we know we start with that. 3 or 4. Multiple gestation, yes. Complications specific to multiple gestation, yes. Let's look at that. Spontaneous abortion, no. Other complications specific to multiple gestation. Let's see if we get it up here. Second trimester, yes. Other complications. I think it's in there. Pretty sure I've seen it before. Other complications specific to multiple second trimester, unspecified, no. Fetus 1, fetus 2. Is there other? It's other because it's both. Other complications specific to multiple gestation, second trimester, other. And we'll open that up. While we're doing that, we'll build another code and see. OB. You have any thoughts? Let me know. Pregnancy, no. Supervision of high-risk pregnancy, okay. Let's look at that. Infertility, ectopic, insufficient, with grand multi, social problem, high-risk supervision of other, high-risk unspecified, molar pregnancy. I think this one means you've got more than normal gestation, other high-risk pregnancy. Let's see. Pregnancies. I'm pretty sure there is a code for monodynamic babies. Let's see what this one. It's not it. Malposition. Okay. This is so good to get in there and look. Complications specific to multiple gestations. It's not applicable. Let's see what this one says. But I think it gave us a list. I'm looking to see if anybody else found it. No. Find code's awesome about giving us. Don't forget you have to get the weeks of gestation. Okay, so let's go to a different tool. Instead of build a code, let's go. This is the last thing we're going to do before we wrap up tonight because it's 7 o'clock. We're going to click a DEX. We're going to do ICD-10, and if this doesn't go quickly, we won't do it because I want you to get out on time. That's very important. And that gives you plenty of homework, right? Let's just see what twin brings up. And it might not bring up anything. It'll tell us. Twin newborn, twinning. No. Twinning teeth, no. Pregnancy, twin. It's not conjoined, but that's in there. And mono. Let's go down to mono. Molar. Multiple gestation, yes. Specified. There it is. 2 or more. Monoamniotic fetus is monochromatic. This is what it was. It was 30.81. Yay, we found it. And here we go, first, second, or third trimester. This is the second trimester. Let's see if this will let me grab it real quick. I think there might be one more character. No. So it's 030812. 2 stands for the second trimester. Other specified multiple gestation with 2 or more chironic fetus second trimester. Code also complication specific to multiple gestations, which there really wasn't anything. This was specific, so there wouldn't be something that goes in front of that. Any additional, and it's the week of gestations, and then you would code her other complications for the hypertension and the cholesterol. Oh, let's see. Chelsea found 031.012, but it's an 8. I would go with the 8 because the O is different. Oh, let me go back that far. But yeah, it's a little bit different. Very good, guys. So that's great. Let's go look at our last slide, which is just a recap to go over. Don't forget, when you're doing opera reports, go look at some adhesences, and in Google Image, look at the codes for repairs, whether they would do packing or not, and why you would do packing. So go educate yourself on that for the disease process. And in addition, I would have you um, then go for the gestations. Make sure you know what trimester, because you always need to know what trimester the mother is in. And when you have twins, that you have a twin A and a twin B, it does make a difference what type of a twin is if there's complications, and anything going on with the mother could be a complication for the pregnancy, and it could be a high risk. Codes could be in there as well. So a lot of fun stuff. Thank you for our person who sent these in to us, and I hope she sends more, because these are excellent learning tools. So that's it, guys. We had a good one. We'll see you on our next one. Don't forget to like and subscribe if you're watching us on YouTube. And come to our CCO Club, where we talk about things like this all day long. Bye.